Hey,
Hey, Kate, how's it going?
good. How are you?
Doing well.
Living the dream.
Oh, yeah. This is great. I get to hide from my own ED because it's like exploding downstairs.
Oh, really? We've been busy too. Have your volumes been coming up?
Very slowly, but now that allergy season's kicked in,
Yeah.
I mean, it was incredible that last year, like, nobody had allergy. At the rate you're coming in now, where was that last year?
I know.
You're really inside, like, no ventilation, pollen wasn't coming in. That's impossible.
It's true. It is bad though.
And you guys?
Yeah, I feel like volumes are coming up. I feel like for the first time I've come into overnights with like a waiting room again and that kind of stuff. So
Feels good.
yeah. No one knows how to handle it anymore though too. Like our nurses are freaking out because we have 30 patients. I'm like, you guys, like this was like every day in the winter. Like
I think as a field, we've probably gotten so deconditioned.
yes.
And like only now realizing like maybe that was really unsafe what we were doing before.
Yeah. Well, I just remember that flu season was so bad and I was burnt and then it went to nothing.
Yeah.
Yeah.
That's good for all of us.
We'll get reconditioned.
Yeah. Even had a couple of nursemaids, people running away and falling. And I forget who was it, Antonio, who presented like that hook sign.
Oh, right. I think it was Rosemary. Yeah, I thought it was the other day. I was like, I should look for the hook sign.
I feel like I've now convinced myself that I can see the hook.
That's awesome. I have yet to try because we always just run in and do it. And I'm like, oh, we should have ultrasounded it. But.
So I actually had a kid who was like 4 or 5, like out of the age, but not quite. And the story wasn't great. So there it was like to X-ray or not X-ray.
Right.
We had a hook. Yeah. We moved it. No hook.
Nice.
Yeah.
Hi, Kate.
Hey, how are you?
Good, how are you? Thank you for presenting.
Yeah, of course.
We'll give everyone till around 1:05 and then we can start.
No worries. Should I see if I can share? Am I able to, do I have
you should be able to
share
yeah.
screen?
Yeah.
Okay, let me see if I can start pulling this up just to make sure it. Awesome.
Yeah, we can see it.
Okay, great. Thank you.
I'm a little curious to find out who's at Grandstand Medical Center, because in my mind's eye, I'm thinking of like a hospital right behind the wall in Wrigley Field.
It's amazing. It's amazing.
I think it's one of the South Carolina sites. It's one of the former Hopkins emergency ultrasound adult folks, I think, is there at Grandstand. It's up in Myrtle Beach.
Yeah, great t-shirts.
We were just out at breakfast with our fellows and all the Yankee fans are in town. There must be a game, or maybe it's the Mets. I don't know. I'm not a baseball person, but there's some New York team is here taking over Baltimore.
I doubt it's the Mets. It's going out on a limb. I doubt it's the Mets.
Adam, you got a response in the chat saying it's Grandstand EM Ultrasound Fellowship from Myrtle Beach.
Nice.
Oh, Grandstand. I thought it was Grandstand. Okay. Well, yeah. Still a good name. Myrtle Beach. Good place to be too.
Yep.
For sure.
And over here, you guys are, everyone's getting busier again.
Yeah. How about you guys?
Yeah, it's been crazy the last couple of weeks. Our behavioral area has been out of control. We are averaging like 40 patients in our ED. So when we have like 45 medicals, like we're getting close to 90 patients in the emergency department, which it's crazy. But yeah, so I think we're getting back to where we used to be before. So
yeah, it does feel like it.
But the behavioral patients is just. I never thought we would get to this point. It's such a problem right now. So it's I'm not sure if it's going to get any better anytime soon.
No, I agree. My husband is on the annual fund board for our kids go to public school in Baltimore, and they were sort of deciding how they were going to spend money on sort of, you know, different courses for the kids versus mental health. And I was like, you got to get mental health. I mean, they have someone there like once a week, and it's such a problem.
All right, so good afternoon, everyone. Thanks for joining again. Today we have Kate from Johns Hopkins Children's Center presenting. So thanks, Kate, for presenting, and you can take it away.
Absolutely, thank you. And just let me know if someone could keep an eye on the chat. I'm happy to respond to questions and hopefully get a little involvement from folks as we go through. So we were just talking about, it's been a little bit busier in our ED over the past couple of days, or the past couple of weeks. So it's led to some good cases. So I've got some cases that we've seen over the past couple of months. The first one is a knee pain. So this was an 18-year-old female with no significant past medical history, who was coming into the PEDS, sent in by her PMD with several days, and it actually sounded, once we talked to her, more like maybe several weeks of worsening right knee pain and swelling. So the story was that she had been in a motor vehicle accident 12 days prior, during which she had struck her right knee on the dashboard of her car. She was seen in an outside hospital then and had knee x-rays, which were negative for fracture. And then in the past 9 days, she had also tested positive for gonorrhea. And this was prior to the change in treatment for STIs, but she had been treated empirically with ceftriaxone and azithro. And had improved, and then had seen her PMD now today for worsening knee pain, with swelling and some difficulty with ambulation, sort of worsening acutely over the past 48 hours. Her PCP saw her in the office and was concerned potentially about septic arthritis with this history of gonorrhea, and sent her to us for evaluation. So her physical exam, she was afebrile. She had normal vital signs. Her right knee was notably swollen and more medial than lateral, but definitely swollen compared to the left. She had sort of prominent fluctuance and just very mild tenderness to palpation. There was no significant tenderness. There was no overlying erythema. She had full range of motion. She did also have a small healing abrasion over the area of maximal fluctuance, but again, no warmth or drainage or overlying erythema. She could weight bear, but it was with some discomfort, but she definitely was weight bearing. So all things together, we definitely had a lower suspicion for septic arthritis. She didn't have any systemic symptoms. Her range of motion was reassuring. But they had already sent labs from clinic, and her labs came back and were pretty underwhelming as far as her inflammatory markers and her white blood cell count. And she had a repeat x-ray of her knee that was normal. So I was with one of our first year fellows doing scanning shift. And so we went in to ultrasound her knee and see what we could see, sort of figure out what was going on with her. And so what we saw, and we're sort of losing a little contact with the skin over the edge of this lesion, but you can see that there was a large anechoic fluid collection that was sort of tracking in the subcutaneous tissues, and then also had these internal sort of mobile septations that you could see as we sort of tracked down this collection, which was actually quite large. We also did ultrasound her knee. There was no effusion in the joint. You can see her patella and her quadricep tendon and then the femur. It did not look like there was any knee effusion, which is sort of what we came away with based on our exam as well. And we were a little perplexed because, again, this didn't seem infectious, didn't even really seem like an abscess based on her symptoms. She was sort of, this had been going on for weeks now, sort of worsening over the past couple of days, but with sort of minimal tenderness and not a lot of overlying skin changes.
Okay.
Yeah.
So where was the area of the collection?
So it's in her subcutaneous tissue, medial to her knee. So she didn't have a ballatable patella, didn't feel like there was a knee effusion, but really in the subcutaneous tissues, medial to the knee joint.
Got it. Thanks.
Yeah, absolutely. So this was her radiology ultrasound, and it was so large that this I thought was kind of cool. They sort of pasted together their different images that they collected. So you could see basically from sort of her mid thigh down to her, mid calf was sort of this large anechoic fluid collection that they immediately said was classic for X diagnosis that I had literally never heard of in my life. And I asked our division chair, who prides himself on his obscure medical knowledge, and he similarly had never heard of this diagnosis. So I'll pose it to you guys, ultrasound experts. Is there a diagnosis that comes to mind for this?
Adam said MCL sprain.
Good thought. It was not an MCL sprain.
And then Matt said Morel Labelle.
Yes, Matt. Is that Matt Moak?
Yeah.
Genius. Matt, how did you know?
Hair also said that.
Oh,
Yeah.
yeah. You guys are smarter than we are. Yeah.
Oh, I've just read your paper recently.
It's amazing. It's amazing. So yeah, so they said, radiology said this is very classic for a Morel-Lavalley lesion, which I had never heard of. So my fellow did write it up. This is apparently a lesion that's described, often seen in adults after traumatic injury, but can also be seen in pediatric patients, typically due to a high impact trauma. So her MVC 12 days prior when her knee struck the dashboard was her high impact trauma. And it's basically a closed degloving injury. So you get tangential forces, such as striking something in your car. It's also been reported in kids from more minor mechanisms. So I'll show you guys a paper, 2 kids described who had minor falls during sports onto their knees. And basically the force of the impact generated by this high energy trauma leads to separation of the subcutaneous fat from the fascial plane. And then with sort of that shearing injury, you get accumulation of blood from the vessels that tear and from the lymphatics that rupture. And so you get this accumulation of fluid in that space based on the sort of shearing mechanism. Also commonly seen when we sort of did our literature review, oftentimes in sort of the pelvic and trochanter region, again from MBC. So kids that come in with like swollen butts and swollen hips can sort of be from this shearing injury.
Can you go back to the image? That last one?
Yeah.
What exactly is so classic about this? Like, which part are they pointing to?
So just the fact that she had this large subcutaneous collection after a traumatic impact that didn't strike, and sort of I think based on your clinical exam and sort of other findings did not seem infectious in etiology, but just this large collection. And they sort of describe also these internal septations that is sort of classic with just this shearing injury.
Got it.
So this was another PEC case report. We sort of submitted it as an ultrasound case report, but this group sort of described 2 kids, 10 and 16-year-old males who fell during sports. Both of them had MRI to confirm their diagnosis. It seems like typically these kids either get CAT scans or MRIs, and I would propose that, if we're just looking for a large subcutaneous fluid collection in someone with the right history, that I think ultrasound should be our modality of choice. And typically these are treated, well, I'll talk about how you can treat them, but in these patients, they were treated with drainage and then compression. This is an image from a figure from their paper. So again, this was one of their patients. So I don't know why classically it seems to be the medial knee that you see. That's what they describe in both of their kids. That's what we saw as well, but sort of medial more than lateral swelling. Maybe it's just that I don't know, maybe you tend to strike that area in an injury. And then they did some drainage, and then sort of post-drainage, the knee looked like that. For us, when we talked to our orthopedic surgery consultants, they just recommended conservative management with compression, ACE wrap, and rest. Our patient was not compliant with orthopedic follow-up, but she did go to her PMD 5 weeks later and had significant improvement in her knee swelling and pain. As far as there is really no standard of care, it seems like, for treatment of these. So you can do supportive care with, ACE wrap, sort of compression and rest. Some people will do local aspiration, in particular if patients are very symptomatic, and sort of locally aspirate. And there are, in the literature, I saw some cases that become more chronic and need things like sclerodesis. So it sort of ranges from very supportive to more invasive.
Kate, 2 questions. One is from Matt Moak. He wonders if the IT band helps to prevent it from going lateral.
Oh, yeah, good thought. Yeah.
And then my question is, you said both cases were confirmed for MRI. Would it be possible to get away without confirming with MRI and just leaving it with ultrasound, even if it's—
Yeah, that's what I suggest. So I think in both of these cases, when I read through that case report, both of these cases presented late, and I think that will often happen. It seems like, initially they're sort of just, treated as a contusion, and these kids both presented much later. In that case report, that was not mine, and I don't remember the institution, but I think their concern was maybe for ligamentous injury or something else, so they did MRI. But yeah, I would be a proponent for not, unless there was some other concern. And I think, especially if the kids present closer to their trauma, especially to community centers or other places, they might be more likely to get a CAT scan. But I would propose that this would be perfect for an ultrasound diagnosis.
Hey, Kate, it's Stephanie. How are you?
Hey, good. How are you?
So we actually had a similar case a few years ago that I had the same aha, like when we sent the patient to radiology, that they said, oh, it's a Morel-Lavalley lesion. I was like, geez, I've never heard of that before. I put a comment in the chat. I'm not sure if you saw.
I didn't see it.
If you use the dual mode, you can scan. You were mentioning that in radiology they kind of pasted the 2 pieces together. You can do that in the dual mode. So if you get one of the sides, then press the dual, and then you update it, you can actually kind of piece the 2 together on the. It looks like you have a mind tray.
Yes, that's awesome. Thank you. I'll have to play with that. That's great. That'll be fun. That'll be fun. All right. Any other questions on this case, guys? Awesome. All right. Speaking of allergies, sorry. All right. Second opinion. Who doesn't love a good chief complaint of second opinion in the ER? So this was a Monday morning shift, and that is what this patient came in for. But it gets a little more interesting. So this is a 10-year-old female with a reported diagnosis of lupus versus JIA in Nigeria, who's coming to Johns Hopkins early on Monday morning, directly after getting off her flight from Nigeria for a second opinion. And that's pretty much the story. So there was not a lot of other information that came with this patient. We were able to gather a little more history from Dad, which was limited. But the story goes that Dad reported she had been diagnosed by physicians in Nigeria within the past year with potentially JIA or lupus after presenting with a year of fever, rash, and joint pain. She had, so the preceding year, so this was, I saw her in February of this year. So sometime last year, she had been started on hydroxychloroquine and prednisolone, which they were tapering down on. And she had been on methotrexate, which Dad had stopped last fall because she was having worsening alopecia. So he had stopped that medication. And really over the past week, she had sort of acutely gotten a lot worse with worsening fatigue, joint pain, hemoptysis, peripheral edema, which was significantly limiting her ambulation. She was having daily fevers and rash. And Dad reports, and again, we sort of had obviously no documentation from the hospital, but that she had been admitted to a hospital in Nigeria. She had been very anemic, which had been going on for quite some time. And appropriately, Dad was concerned about her getting a transfusion in Nigeria, sort of not knowing how blood was processed there. But during this admission, he had been able to donate blood, and she did receive a transfusion. which he felt like sort of worsened her as far as her edema, her fatigue. And so they had eventually been discharged, and he had gotten on a plane and brought her directly to Hopkins to sort of get a second opinion for what was going on. She was very unwell appearing. I was actually surprised that she had been sort of allowed on a flight, that no one was sort of questioning her ability to tolerate that flight. She was tachycardic, she was tachypnic, she had borderline blood pressures, and she was satting 94% on room air. She looked very chronically ill appearing, cachectic. She was very uncomfortable. She basically would only lay in the fetal position. You could get her to roll from side to side, but she would sort of lay on in the fetal position. She had alopecia, she had tacky mucous membranes. Her face was quite swollen, and obviously sort of not knowing her baseline, it was a little bit unclear if it was sort of moon facies versus if this was part of her sort of worsening edema that the family was describing. She was tachycardic. She had no murmurs appreciated. She was definitely tachypnic with fair aeration, definitely decreased breath sounds at the bases. She had a very distended abdomen with diffuse tenderness to palpation. She really wouldn't let you touch her belly at all. So it was difficult to assess for organomegaly. And just generally sort of very uncomfortable with any abdominal examination. She had cool distal extremities, her cap refill was delayed, and she had this sort of very chronic appearing rash on her body, scattered on her trunk, extremities, and face. So we decided, I mean, it was clear that she needed some figuring out, but we went in to sort of just see what we could see on ultrasound. Her belly exam was concerning. It seemed like it was probably ascites, but it was a little bit hard to discern at all. And so I apologize for these views because they were quite limited due to her discomfort. And again, she was sort of only laying in the fetal position. But if you believe me that this is a right upper quadrant, you can see her kidney here. And I know we're a group that doesn't sort of always love measurements and things like that. To me, this sort of struck me as a generously sized kidney in this sort of very small, sort of looked like chronically growth stunted child. And you can see a little bit, it doesn't, I don't think it displays great here, but there was a quick glimpse I got of Morrison's pouch, which maybe there was a small amount of fluid. Certainly there was not a huge amount of ascites that I could see, but a little bit limited because of her discomfort. And if you guys see other things, please jump in and shout. I think sometimes you guys appreciate things that I may not.
Lei Chen from Yale said the liver in funny position.
Yeah, and I agree. And again, some of it was because I couldn't really get her to lay on her back, and it was difficult, but I was right. I was trying to sort of figure out, you know, her kidney seemed to take up the majority of my image, and I was, you know, sort of having difficulty a little bit. But what I could see, there wasn't, I didn't appreciate a lot of ascites. This was her left upper quadrant, again, limited, but we can see a little bit more here. You can see that she has a pleural effusion, definitely on this side. And you can see at the very end of this clip, kidney will pop in a little bit there. And I didn't appreciate, again, sort of behind this rib shadow, I didn't appreciate, again, sort of a significant amount of ascites, but definitely some pleural effusion. So again, sort of not able to tolerate a lot of abdominal examination. I couldn't actually get bladder views on her. So we moved on to cardiac. And this was her parasternal long. Thoughts on this image?
Stephanie Cohen said not good, but it looks like a small peripheral effusion.
Not good sums it up. She's got, you know, you can see some pericardial effusion here. There's a little bit of effect. You can see, you know, not seeing sort of all of the right ventricle here, but seeing a little bit of effect of this effusion. And function just looks pretty poor. This was her EPSS without even measuring this, certainly looked more than 7 millimeters. And then finally, her parasternal short looked like this. So this obviously was helpful because we knew she needed to go either to our CICU or PICU, and also sort of not having any information about her. You know, we had heard that she was potentially anemic, but with this sort of, and you know, she looked clinically slightly intravascularly depleted, or probably more than slightly, but she was maintaining her blood pressure, so she wasn't someone that I was going to start bolusing. And if she needed volume, probably, you know, blood if she needed it. But it turned out she actually, that was sort of one of her better lab values. These were her lungs. So again, with her sort of tachypnea and work of breathing, she basically, anywhere you put the probe on her sort of mid to upper back, there was a large effusion tracking on both sides. She had large bilateral pleural effusions, lots of B lines, as you guys can see. There's a couple other images, just large anechoic effusions on both sides. And similar here, lots of B lines. So certainly some, you know, she definitely has cardiogenic failure. This was her X-ray. Radiology called us in a panic about her X-ray, and we said, you know, we're aware she, you know, looks to have very poor cardiac function. We're not surprised by her degree of cardiomegaly on this X-ray. And then her labs started to come back. So she actually, you know, was not anemic, which was sort of one of her better lab values. Unfortunately, she was in significant renal failure. So again, sort of made our fluid management more challenging. She obviously had elevated inflammatory markers. This all sort of presumed at this point to be lupus as far as her underlying diagnosis. Her troponin was elevated. Anecdotally, what's the highest pro-BNP you guys have seen these days?
4,000.
4,000? Yeah, hers was 312,000.
Must be a different unit, Kate.
Maybe it is, maybe it is. Her EKG was not terribly remarkable, and her echo sort of confirmed. We got a sat echo, which confirmed that she had severely decreased LV systolic function. They were estimating her EF to be about 27% with the moderate pericardial effusion that we saw. So all things in total, with these sort of findings, we definitely expedited her care to our cardiac ICU. Where she was promptly intubated and put on a milrinone drip. Unfortunately, it took 4 attempts to intubate her, but luckily she didn't have any sort of arrest or decompensation during the attempts. She had a very, as you might imagine, sort of a very long and protracted course. She had a month-long PICU stay, or CICU stay, I should say, sort of intubated, extubated, re-intubated. On and off drips. She was initiated on CVVHD for her renal failure. They ultimately, the following day after we admitted her, she did have a chest tube, and they did end up, the following day, they felt like her echo showed worsening of her pericardial effusion with some evidence of tamponade physiology. I didn't really appreciate tamponade physiology on her, sort of on our POCUS, and I don't think that they really, on their initial one, were as concerned. But the second day had some tamponade physiology, so she had a pericardiocentesis. She was started on methylprednisolone, cyclophosphamide, and rituximab, and just was discharged home earlier this month after a 2-month hospitalization. And she actually, impressively, her creatinine had improved enough that she's now off dialysis. Her echo had improved. I think her last EF that I saw was like 45 or 47. So impressively responded to treatment. So that was good news for her. So sometimes the second opinions are real.
I'm confused, Kate. What's the unifying diagnosis? Did she really have lupus? And
It was all lupus, yeah. And I think just it was sort of hard to know what the treatment had been in Nigeria, and she had sort of been on and off medications, and so I guess, probably that's, why she acutely decompensated. But it's a little bit hard to know just sort of based on lack of information from the preceding year. Yeah, but it ultimately is lupus, and she will continue on these therapies.
I'm shopping around a manuscript for the 5th journal, may come to yours, Kate, looking at children who had undifferentiated shock in sub-Saharan Africa. And very often they had previously undiagnosed or at least unrecognized cardiac disease.
Yeah. I mean, I think, right. So is it congenital cardiac disease or what kind of?
A whole combination of it, such as
yeah.
this child who had acquired pericardial effusion.
Right. Yeah.
And they have many undiagnosed rheumatic heart disease, as you know, but sometimes we're surprised by something like this.
Yeah. No, it was very interesting. I don't get to do a lot of global health, but sometimes it comes to you. So, all right. Any other thoughts? I'll move on. So this is a case of facial pain and swelling. This was a Sunday a couple of weeks ago. I was working, and we had a 19-year-old undocumented male from Honduras who was presenting with 3 days of worsening right jaw pain and swelling. He told us he had never received dental care in his life, and he has had multiple broken teeth from fights years ago. His examination, he had extremely poor dentition. He essentially really had no molars. There was a little bit of tooth that came above the gum line, but they were pretty much all broken off, and looked to be sort of very chronically poor shape. He had induration and tenderness to palpation along his right lower mandible, with a small area of overlying erythema. There was no appreciable fluctuance. There was no sort of streaking up his face. His intraoral examination, other than sort of this very poor dentition, couldn't really appreciate any periapical abscess or focal gum swelling. And his neck had shoddy anterior cervical lymphadenopathy. So obviously not an uncommon presentation, concern for dental abscess. I'm curious what you guys do in your institutions as far as imaging, or what you guys typically do for these versus just antibiotics.
No imaging, usually just physical exam.
Yeah, we, and I don't know if it's sort of how it differs. We sadly, sort of one of the big gaps in our care is we have no dental services whatsoever. So anyone who sort of, even patients who are admitted with sort of facial cellulitis from a dental process, there's nobody who can, who sort of does these dental abscess drainages. We don't really have access to dental care, so we have to send them to University of Maryland. So at my prior institution, we had dental residents, we had the ability to get Panorex films. We don't have those capabilities here. So, I mean, definitely based on the story, he needed antibiotics, but I was just curious, if they're, sort of differentiating pulpitis, which, obviously sort of more localized infection versus a periapical abscess, which can present similarly. So ultrasounding over his jaw, you could see sort of his teeth here, and then obviously this sort of anechoic, hypoechoic collection, which looks to be sort of his periapical abscess in the area that was bothering him.
Wait, how do you do this? Through the cheek or inside his mouth?
Yeah, so just probe, sort of, you have to go a little bit above the mandible so that you are not getting that, sort of getting blocked by the bony structures there, but then you can sort of easily find the teeth and sort of see them as these, sort of ridged areas. And it was pretty easy in him just to go over his area and sort of look for this abscess. And then putting some color flow on it, obviously some hyperemia of the surrounding tissues, but clearly there was a fluid collection that needed drainage, except we don't have a dental person to do it.
Kate, I'm still confused. I'm so sorry. So the probe is outside the patient's face.
Yeah. So this is all, we don't have endocavitary probe. So this is a linear probe, just over sort of the cheek, right above the mandible. Does that make sense?
It does, but I'm trying to see how you subtracted out the face, the cheeks.
This is sort of right over his, like right here. And then, so if you're right above the mandible, you'll get
Yeah.
the teeth. So you'll see the teeth here.
Yeah.
And this is his cheek, his sort of sub-Q tissue here. Yeah. So this is like cheek and then sort of deeper structure.
Okay, I see. Got it.
So, and these are just sort of, again, sort of going down, then further down his neck, he had a bunch of, as you might imagine, some cervical lymphadenopathy as well. So I found this study, which I thought was interesting. It was very small, but they were looking at comparison of bedside ultrasound and Panorex radiography for the diagnosis of dental abscesses in the ED. Again, I don't know how common it is. This was an adult population. I don't know how common it is that folks get Panorex films for this indication. I agree with Rosemary that, whether or not I think it's if it seems like an abscess, I'm going to start them on antibiotics and have them follow up the next day in sort of our free dental clinic across town. But they looked at a retrospective review of 19 adult patients who presented with atraumatic facial pain, swelling, and toothache. And again, sort of trying to differentiate pulpitis, which is a more localized infection, to a periapical abscess. All of their patients received POCUS, followed by Panorex x-rays. And compared to the Panorex films, POCUS had sensitivity and specificity of 92 and 100% respectively for a dental abscess. So for us, I think this could be helpful in sort of, because of our lack of access to dental care, sort of figuring out if, and even if it's a bigger fluid collection that maybe we need to sort of bother ENT to drain or someone else as far as sort of their acute management. But he got sent out on antibiotics and hopefully followed up in dental clinic the next day for drainage of this abscess. I'm sorry, Leah, they had a nice figure in this paper actually sort of showing how to do it, but really just sort of, right above the mandible, had an ultrasound right there. Generally easier if the patient's sitting up a little bit or at least sort of sitting back on an inclined stretcher. It's pretty easy to do. All right, moving on. Friday night in the ER, our favorite overnight time. And I walked into my shift 2 weeks ago to my first patient was chronic abdominal pain. And this was, as I was saying earlier on, one of the first nights recently. Our volumes have been coming up. So we had a decent sized waiting room as I came in for my overnight. And this young lady was here. She was an 8-year-old with a history of constipation and now with 4 months of intermittent abdominal pain. She had been seen by her PMD who had referred her to GI. She had her upcoming appointment next week, but hadn't been there yet. And mom says really her abdominal pain has been worsening over the past day. She had one episode of non-bloody, non-bilious emesis. Mom was wondering if this was her constipation and gave her some Miralax and suppository with only sort of small stool output. And so when I came on for my shift, the resident had already seen her and her description of her examination was not terribly remarkable. So she had stable vital signs. She was pretty comfortably sleeping on her abdomen when she went into the room, and she had diffuse tenderness to palpation, no true focality to her abdominal exam, no rebound or guarding. She had bowel sounds. And the resident, I think as we all do with some of these cases, sort of didn't know sort of what next. She felt like this didn't seem consistent with an acute surgical abdominal issue and was not inclined to sort of do a lot of advanced imaging. And she didn't feel like this was an infectious etiology, given sort of the chronic nature of it. So she thought we didn't necessarily need labs, but she proposed maybe we just start with an x-ray, sort of see what's going on. If she's comfortable, can she go home with PMD follow-up? So we weren't sort of clear exactly how we were gonna approach this. And I came into my shift pretty well caffeinated. And like Adam Sivitz likes to say, I wanted to sort of go in and cognitively unload and sort of figure out what was going on with folks and make a plan. So when I went in to see her, I actually just went in with the ultrasound machine. And this was her right upper quadrant view, which looked pretty normal, unless you guys have other thoughts. And so then I moved on to her left upper quadrant. Again, pretty normal. And then finally, bladder images, so transverse. Any thoughts on her bladder ultrasound?
Thoughts about what's above her bladder?
Yeah. What does it look like to you?
I put in my comment, it's possible it's like a teratoma, but also could be like an old perforated appendix that's a collection.
Yeah.
But I favor my first choice.
Yeah, I sort of described it to the mom as I was doing this. And I just saw this fairly large. So it was in the midline. It obviously was sort of superior to the bladder as I fanned through the bladder, sort of cystic mass. You can also see there are some other components. Let me see if I can freeze it in the right spot. Let me go back. Oh, sorry, guys. So there were also some components that maybe looked, maybe it's not letting me freeze, that maybe looked like there were some calcifications that had some shadowing. Let's see if I can do it this way. So there's, then there's sort of this mixed echogenicity stuff, sort of around this sort of cystic mass. And then a few areas where maybe it looked like there were some calcifications with some shadowing. It was a little bit hard to tell, but sort of in here, if you guys can appreciate that, it looked like there was maybe some shadowing. When I tried to sort of look at it in orthogonal planes, like it definitely crossed the midline, seemed to be in the middle. I couldn't appreciate her ovaries from this transabdominal view, but yeah, and so here's a few other images I tried to capture of it. So again, sort of cystic components, but also some mixed echogenicity and maybe some calcifications as well. It did not have, I think I have an image, did not have any internal vascularity. So this was her color image. There was no internal vascularity of this mass. So she had a radiology ultrasound, which confirmed a 9 by 6 by 9 centimeter large pelvic, predominantly cystic mass, with thick internal septations located superior to the bladder, which seemed likely ovarian in origin, again, with no internal vascularity. So we were sort of, like you, Lei, favoring a cystic teratoma. So we talked to surgery. She ultimately got a CT scan, which confirmed that this was a mature cystic teratoma. She was admitted to the surgical service for planned resection and then overnight had worsening abdominal pain after admission and developed some fever, and they were acutely concerned about ovarian torsion. So she was taken emergently to the OR at that point. And it looks like from their op note, she was having some torsion. Unfortunately, there was very minimal ovary to save on that side anyway. I think they only described sort of a rim of remaining ovarian tissue attached to this large teratoma that they resected, and she did well otherwise. So that was a good one. The resident's jaw kind of dropped when I came out and I said, she's got a large cystic mass in her belly. And she was like, oh my God, I missed it on exam. I was like, no, you didn't miss anything on exam. But yeah, POCUS definitely helped us with this case of chronic abdominal pain. You guys probably know teratomas are the most common ovarian tumors that we see in children. And typically their presenting symptoms are due to the sort of the compression that they place on other structures in the area. So these kids will often present with constipation or urinary retention. as sort of their presenting symptoms, which is, you know, a little bit what had been described in her case was sort of worsening constipation that ended up being her mass pushing on her bowel. This was a case report I found from Jen Marin's group, where they described diagnosis of a cystic teratoma. Sort of similarly, it sounded like their patient presented with quite a distended abdomen, sort of distended and tense abdomen. So I guess a larger teratoma than we saw in our patient, but again, had presented with sort of chronic constipation and abdominal distension. All right, questions about that last case? I'll move on and hopefully finish up this last one with time for questions if you guys have any. This was an interesting one just because I felt like I hadn't seen any true cases of this and then have had several in the past week. This was my Monday shift this week, and we got a EMS call. City medics were coming in with an 8-year-old male with 1 week of fevers, vomiting, and diarrhea. He had had 2 prior ED visits at one of our outside hospitals in the past 4 days for these symptoms. And he was ultimately diagnosed with bilateral AOM and was started on amoxicillin. And now this morning, mom said, you know, his fatigue has really worsened. He got up this morning and started saying he couldn't breathe. So she called EMS and they were en route to us. They reported his GCS to be 15. His blood pressure was 145/77 and his D-stick was 122. We said, great, we will meet you in triage. In triage, his vitals were not as good as they had reported. So his heart rate was 122, his respiratory rate was 58, his blood pressure was 70/30, and he was sounding 100%. We quickly brought him back to one of our critical care rooms. He was uncomfortable, appearing in moderate respiratory distress. He had bilateral conjunctivitis and a strawberry tongue. He was tachycardic and tachypnic, but clear breath sounds. And he had violaceous macules scattered on his arms and trunk. Mom said the rash had started the prior week with his fevers to 104 and had improved after his first dose of amoxicillin 2 days ago, but was still present. Before I get into his ultrasound imaging, you guys have any thoughts on differential for him?
I mean, 2019, I would have said Kawasaki's.
Yeah.
Versus, you know, meningococcemia or something more sinister. Yeah. But since we're in 2021, I think we all have seen or heard of it.
Yeah, and I think just, you know, sort of hearing the story and getting his initial vitals, right? Yeah, we were sort of, is he sepsis versus MASC, some viral, you know, sort of viral sepsis or bacterial, yeah. So we went in with our ultrasound, and so here's his peristernal long axis. Thoughts on this image?
Dilated LV, sort of moderately depressed function.
Agreed. Yeah, that's what we appreciated as well. This mitral valve was certainly not approaching this intraventricular septum, and it seemed like there wasn't great squeeze here, that this LV is sort of, I agree with you, is dilated. This was his peristernal short. Again, doesn't appear to be great function.
Matt, Mook mentioned in the chat that the left atrium looked generous on the previous slide.
Yeah, yes, I agree as well. Here's his apical 4-chamber view.
His RV looks generous, Kate.
Yeah. So I'll tell you that on, he did, and he also ended up with a stat echo because we saw this depressed function. And he did have both mitral and tricuspid regurg, as well as depressed LV systolic function. So here was his EPSS. I'm curious, I know we have talked about before, a lot of us sort of don't do measurements or calculations. I actually put this into a calculator just to see how my estimated EF would compare to what cardiology got. Do any of you guys do calculations for these?
I do quite a few like fractional shortening EFs,
Uh-huh.
mostly just for funsies. I've had a few where it was like, I don't know, like wanted a harder number because it didn't seem like maybe for like a general population mean, the number would, like the gross would probably be okay, but for the body I was looking at, it felt like I should see more.
Yeah, I was just kind of curious because I knew it was gonna, I mean, my gestalt was Rosemary's gestalt. This was at least moderately depressed function. But I wanted to see if I could come up with a number, just curious how well those, how well we can estimate it compared to cardiology. I was getting a number sort of high 30s, low 40s, and he got a stat echo after he was on pressors and they were getting 45. So I was a little bit off, but I think, you know, it's, I certainly appreciate it was not normal.
Kate, I don't know, did you have, that apical floor was a little hard to tell, but
Yeah.
it was actually pretty noteworthy. I thought that the TAPSE looks great. So like the right side seems to be functioning like quite well, but
Yeah,
we're not quite seeing the whole, you know, free wall, but
yeah. So his right ventricular function was normal. So it was just LV dysfunction, and then he had, as I mentioned, some tricuspid and mitral valve regurg that actually worsened during his hospital course. So we were quite concerned about cardiogenic and vasogenic shock, likely in the setting of MASC, given his presentation. With rash, sort of mucosal changes, fever to 104 for 7 days, vomiting, diarrhea. He seemed to sort of check every sort of clinical symptom box that I had heard of. So he got, while we were mixing our norepi infusion, and I apologize, I didn't save a clip. We actually, at the same time we got him, we were getting a unbalanced AV canal who was satting 50%. So we were kind of running between rooms, but his IVC actually looked decently sized. He certainly did not have for, you know, sort of all of his potential fluid losses, he did not look terribly volume deplete as far as his IVC. But while we were mixing our norepi infusion, he got 2 normal saline boluses, but we weren't really able to get him much above 70/30. So he got started on norepi and got empiric ceftriaxone, just sort of broadening our differential to sepsis. His stat echo, as I mentioned, showed diminished LV systolic function with mild to moderate mitral valve and tricuspid regurg. His labs had quite a few abnormalities, so I highlighted the ones that were sort of most significant. He had the thrombocytopenia, as has been described. He was hyponatremic. He was in acute renal failure with a BUN and creatinine of 71 and creatinine of 5. His lactate was pretty normal. His CRP, our scale is milligrams per deciliter. So for us, less than 0.5 is normal. So he was quite inflamed. His troponin was up, as was his proBNP, which came back after he was in the PICU, was quite elevated as well. And sort of all the other MASC labs were notably abnormal, ferritin, sort of all of those things. So he received IVIG ×2 and methylpred with defervescence. He was started on aspirin and a heparin drip and will be converted to Lovenox. As of what is today, so as of yesterday, his troponin was trending down, as was his proBNP. Unfortunately, his echo was worsened. So this was from the following day, so the 27th. He had moderately diminished LV systolic function, which was now down to 37%. And now some diminished RV systolic function, and now with some prominent posterior descending coronary artery as well. Previously his coronary arteries had looked okay. So hopefully he will do okay. It sounds like he hopefully will improve after his treatment for MISC. but it sort of was interesting because now I've had two. We had another one earlier this week, a 6-year-old who presented very, very similarly and also has been described. He had an ultrasound that was also concerning for appendicitis with his abdominal pain and sort of MASC stuff. And we talked to the surgery team that we thought this was less likely acute appendicitis and more likely MASC, and they elected to watch him on antibiotics. And interestingly, his sort of right lower quadrant ileocecal inflammation has improved with time. So yeah, we've had a couple, and I don't know if you guys are seeing more. I really hadn't seen much sort of prior. I don't know if it's the new strains or what, but definitely some classic cases.
It's a great case. I'm curious, how did he do after the 220 per kilo boluses? It looked like his respiratory rate was pretty high, so I'd be a little nervous.
Yeah, no, it's
that
a
much.
good point. Yeah, and again, we were sort of focused on maintaining his blood pressures. And I think, where he definitely was sort of tenuous from a respiratory standpoint. And I could see the need arising for potential intubation. He did not need to be intubated in the PICU. And again, because it just took us a little time to get our drips mixed. So we needed to support his blood pressure in the meantime. We did put him on oxygen. Again, sort of thinking sepsis, and before we sort of knew his cardiac function. But yes, he remained quite tachypnic, but he did not need to be intubated. And I think there was obviously, sort of, and I don't know if you guys listened to the CHOP PEM podcast, but they had a nice talk on MASC. And I think for him, there were both components of cardiogenic and vasogenic shock. A lot of things, while obviously it's sort of a balance because of his cardiac function, his renal function dramatically improved with hydration. So his creatinine was down to like 1 by the next day. So he I think was sort of had sort of multiple mechanisms for his shock, and it was a tenuous fluid balance, but yeah, I agree.
Okay, great case. This is Lei from Connecticut. I think I would give yourself more credit. I would say that the post norepi echo shows a slightly higher EF than you got. We can see dramatic differences in EF pre and post the infusion of a vasoactive agent. We've had maybe half a dozen cases like this over the last few months that you can, to your and Matt's point, do you actually want to get that number? I think for longitudinal follow-up of a patient, maybe those numbers are actually helpful. Say, what is the pre-epi or nor-epi EF using our calculations and using the same approach to demonstrate that, not just subjectively the function looks better, but actually using a number. So I think maybe it has some longitudinal value for a specific patient.
Yeah, that's a great.
Yeah, also for us, when we do a focus, we always look at the IVC, both in transverse and longitudinal views. And I think that gives you an idea. As you said, this IVC might look plump, could be from a variety of reasons. One is that he's intravascularly replete, or he's got congestive heart failure, probably a combination. And I think, giving fluid bolus was probably not the wrong thing. At least you were obviously aware that, he also needed some inotropic support.
Yeah, no, absolutely. Those are excellent points.
Hey, Kate, it's Stephanie. In Atlanta, we're still seeing MISC. I had a non-critical case the other night, and the mother was just in complete shock because she said, no, my child has not had any COVID exposure, but the antibodies did come back positive. But what I wanted to ask, I guess the group, you mentioned that you started norepi for pressor support. In our institution, we're mostly using epi as our first line pressor. And I'm just curious what other people are doing and what's their thought process.
Stephanie, this is Lei again. I think thought process and evidence are probably not necessarily consistent. I think the thought process for norepi is that it gives you better cardiac filling. It improves your diastolic blood pressure, has a more alpha effect. So we tend to get norepi. But having said that, our pharmacists as well as our ER nurses are much, much, much more comfortable whipping up a epi drip than a norepi drip. So sometimes we do sort of, start epi, and then when the PICU comes down or when the kid goes to the PICU, they switch over to Mirano and norepi or combination. I don't think there's enough evidence to say, one thought process is more coherent or consistent with evidence, just because we don't have enough evidence, I don't think, unless others have more up-to-date information.
No, I agree. I think, and I sort of sometimes think, norepi and warm shock, this kid felt pretty sort of peripherally warm to me, and epi for, sort of cold shock kids. They actually ended up putting him on epi in the PICU. And so I don't, sort of know what their sort of logic was, in that case, but yeah. And I guess, a lot of it is sort of familiarity in your institution and what's sort of most readily available.
Yeah, the last one I had that was MISC was sort of similar. It was like, wasn't horrible function, but it was probably 40s. Put them on epi and cards came down to their echo probably like 30 minutes later, and EF was fantastically better. Blood pressure was also like boundingly better because the resident had gone in there and gotten really aggressive and ramped it up real fast. I don't know.
Well, thank you guys. If there's no other questions, I'll wrap it up, but thanks for listening.
No, thanks, Kate. That was awesome cases. So thank you again for presenting, and thanks again everyone for coming in this Thursday. Next week, just letting you guys know, we'll be having 2 lectures again. So just review my email that I'll send next week. But otherwise, thank you everyone for coming, and Kate, thank you again. That was great.
Absolutely. Thank you guys.
Thanks, Kate. Bye.
Really impressive, Kate. Thank you.
Yeah.